When we give patients with MDS chemotherapy, there are specific challenges in that patient group. And it has to do with the MDS diagnosis. So first, the median age at diagnosis is 72. So many patients may have coexisting comorbidities, which could limit our therapeutic options. And another issue is that many patients have already profound cytopenias, low blood counts. And one of the major side effects of the chemotherapy that we give to treat MDS is low blood counts. So in thinking broadly about the types of chemotherapy the patients with MDS receive, they would fit into two large groups: induction AML-like chemotherapy and hypermethylating therapy. So we'll start with the induction AML-like chemotherapy. This is pretty aggressive. We generally reserve this for patients who are younger, without a lot of comorbidities, who potentially have the option of a curative approach with allogeneic transplantation. And there is a debate right now in the experts whether patients should receive induction chemotherapy at all, or whether they should receive hypermethylating therapy combined with another agent like venetoclax, for instance. So that is a debate that we're having, and there are clinical trials that are planned to address this issue. But for now, induction chemotherapy is still used to treat some patients with MDS. They can have side effects of infections. They can have side effects of low blood counts. It does require that patients be hospitalized, at least for the duration of the administration of the induction chemotherapy. The blood counts don't tend to come back until about 3 weeks after the administration of the induction chemotherapy. So they may have a lot of side effects with infections, and they would likely need to be heavily transfused during that period of time. Now, when thinking about hypermethylating therapy, they tend to have a lower side effect profile, which is the benefit of the hypermethylating therapy. But on the downside, when you look at the complete remission rates, it tends to be less than what you observe with the induction chemotherapy. But the hypermethylating therapy does lead to less hospitalization for IV antibiotics. They can be given outpatient, so patients don't need to be admitted. So that's the benefit. Both azacitidine and decitabine, which are the two major types of induction chemotherapy, are generally given intravenously. Both are being developed in oral formulations, and azacitidine can also be administered through the subcutaneous route. But for right now, if you were to receive azacitidine or decitabine, it would have to be given in a clinic or in a hospital. And for that reason, because of the way most clinics are set up, the weekend administration is not a possibility. So many of these patients are just getting 5-day treatment of hypermethylating therapy with either azacitidine or decitabine, and they have to travel from their home to the clinic to receive the treatment. The hypermethylating therapies may cause some mild nausea, and they may cause cytopenias requiring transfusion dependence.
I think one of the challenges with the use of hypomethylating agents in the long run is that, as we discussed, they often require frequent administration, around 5 to 7 days each month. And generally, what we have found out with experience, and there's clinical data to support that, is that if patients who are responding stop treatment, the MDS is almost always going to come back and it becomes resistant. So even if you try to restart the hypomethylating agent back, it's very unlikely to result in another response. So we run into this situation often because some patients can have response with hypomethylating agents that last for years, but they are just tired of coming back and forth 7 days every month to get the hypomethylating agents. And we try to overcome that by sometimes spacing the treatment to every 5 or 6 weeks. But ultimately, we unfortunately have some patients who just say, you know what, I'm done, I cannot just keep coming. Especially when they don't need blood transfusions, so they are just coming to get the hypomethylating agent injection. Another situation where we commonly, I think, have a problem with IV treatments is that we have patients who get taken off quite quickly, maybe in the community setting where they get 1 or 2 cycles and the physician don't give the hypomethylating agent enough time to work. Generally, as I mentioned earlier, those drugs can take 4 to 6 cycles before we see response. So we generally try to persist on the treatment until the patient responds. We generally don't continue beyond 6 cycles until unless the patient has a response. But I think, again, chronic therapy for years with hypomethylating agents that require intravenous or subcutaneous administration is a problem, and definitely having an oral alternative will make things easier for many patients. The use of hypomethylating agents basically could be subcutaneously or by injection. So subcutaneous use is actually somewhat faster. It can, take 10-15 minutes to give the subcutaneous injection, so it's very, very fast. However, even in the most efficient places, the patient has to come, register, probably wait in the waiting room, and then leave back. So probably takes a good couple of hours for, in any single day for 7 days in a row for patients to get the hypomethylating agents. Sometimes in some centers you get a weekend break, so the patient will get the azacitidine from Monday to Friday, and then again on Monday and Tuesday with a weekend break. So it's a good commitment for a big chunk of the month, and 2 to 3 hours each time. If they live far from the center, they have to drive maybe 1 hour back and 1 hour, 1 hour each way. So that could take a lot of time. With intravenous use, basically, with decitabine, it probably takes less than an hour to do it. But again, the same issue related to frequent visits, and also on top of that, you need an intravenous access because to give the intravenous drug frequently, and that comes with some risks of infection and clotting of the venous axis, and the need of flushes to make sure it functions. Some patients do not like to have one of those indwelling catheters, but then they have to be stuck each time, like the 5 days when they come for the decitabine, or the 7 days when they come to the azacitidine. Each single time they have to have a temporary intravenous cannula put in and removed, which comes with pain and bruises and discomfort to the patient. So definitely some issues come with that.